Someone is not on mute. Right, good. Okay. Well, welcome everyone. Thank you for those that are joining us for our inaugural monthly webinar series on topics to help researchers in the space of patient-engaged research, microbiome, inflammatory bowel disease, IBS, mental health, and diet. And we're starting with issues of evaluating fecal microbial transplant in clinical trials. And I'm Paul Moayyedi, and I'm delighted to be speaking with, I'm from McMaster in Hamilton, and I'm delighted to be speaking with Dina Kao from University of Alberta in Edmonton. So welcome everyone. First, for those of you that are not aware, Imagine is a network of investigators that are evaluating the interactions between inflammation, the microbiome, diet, in causing IBD and IBS and associated mental health disorders. We hope to transform the management of IBD and IBS and associated mental health issues. And this is a SPORE network funded by CIHR. So neither of us have anything to disclose. And these are the CanMed roles. And what we aim to do during this 1 hour session is to discuss how best to design fecal transplant studies. The emphasis here is on how to design trials. It's not when to use FMT or the clinical applications. It's simply what to think about when designing these studies. Unfortunately, this is an emerging area, so we can't tell you definitively everything that should be done in every circumstance, but hopefully we will give you things to think about when designing the studies, and maybe pointers in which direction you might go depending on what you're studying. So the topics we'll discuss is FMT donor issues, the considerations with the recipient of the fecal transplant. When you're doing a randomized trial, you'll have a control arm. So if you're comparing fecal transplant against a placebo, what is your choice of control here? The duration and frequency you might want to give for fecal transplants, and then regulatory considerations. And I will present the first 4, and Dina will present the last bullet point, but I'll be asking Dina for her input along the way. And then at the end of this, we'll have a question and answer for 10 minutes. By all means, type your question as you think of it. Please, I would ask you to do it to everyone. If you do it to me or Dina personally, then we may not see it. And it is Ida Fernandez, the director of the executive director of the Imagine Network, who will be fielding the questions. So please ask questions to all. Okay. So certainly this is a timely topic. The explosion of FMT research is impressive. This slide is a little out of date now, but over time, fecal transplants trials, randomized trials have increased from virtually nothing to quite a large number registered over the last year. And if we look at the countries that are doing this, the USA leads the way, China is second, and Canada is third. Now, Canada is a much smaller country than either China or the US, so per head of population, we're doing extremely well, and it has to be said, as are Israel. And maybe those top 4 countries there are probably leading the way in terms of either number of trials or trials per head of country. And it's nice that Canada is part of that. So if you're going to join that club and decide to do a fecal transplant, what should you think about? Well, the first thing you need to think about is what donor, how you'd screen them, the type of donor, and the stool preparation. In terms of screening, I don't want to give you an exhaustive list, and indeed Dina will touch on this later when we talk about regulatory issues. But basically, in choosing the donor, we have traditionally chosen people who are not recently on any antibiotics or probiotics, and if they take antibiotics, then they cannot be donate for at least 3 months. They complete a detailed health questionnaire, which also addresses mental issues. But I would emphasize that the way we do it anyway is we just ask the patient. We don't do extensive screening questionnaires to make sure they don't have depression or anxiety. We just ask them if they have that. And of course, and the other thing we do is we try and exclude elderly, those over 65. We exclude those that are obese. Because of the association with obesity and stool and microbiome, although I'd have to say that is far from certain. But just to be safe, we do that, and that's why we also screen for mental health and indeed any chronic disease. They have to be serology negative for most known diseases, and we also evaluate the stools for most pathogens, including, of course, C. difficile, and also antibiotic-resistant organisms. Again, a wide variety, but would emphasize the extended spectrum beta-lactam microorganisms, as an E. coli, ESBL, was responsible for. Again, someone has their microphone on, so if they could switch it off, I'd be grateful. You need to screen extensively. You need to involve infectious diseases and also microbiology. And Mike Surratt is providing a great service now in our lab. And then you've got to decide, when you have your donors, what type are you going to use for your trial? And you've got a number of choices. You could choose a related donor. So do you choose a brother or sister, or mother, father, child of the index case? Do you have an unrelated person? And that unrelated can be as close as a spouse or as distant as a friend, but essentially they are known to the donor. You could just choose a healthy volunteer who donates stool on a regular basis to provide for these trials. And that can be an individual healthy volunteer, or you can pool those healthy volunteers all together and use that pool stool samples as your approach to using a donor. So Dina, any thoughts on which is the best way to go for a randomized trial?
Yeah, so I can tell you from in our center, we're using sort of unrelated, completely anonymous donors, and that has a lot of advantages because they come in and you screen them, and they can be used over and over. I'm not quite sure about pooled donor approach right now in Canada, because I think that is something that Health Canada is going to frown upon, because in their guidance documents, they did say, yeah, they want you to manufacture FMT from a single donor. And I know there are some studies from Australia where they are using pooled donors, and the idea behind that is that maybe there is increased diversity in that approach, but then at the same time, there is a theoretical consideration. Perhaps you may also increase the potential transmission of infection when you have multiple donors. And so I think there's the pros and the cons, and I think based on the published literature, the outcome of the pooled donor approach, the efficacy doesn't seem to be improved compared to single donors. So that's my personal take on it. That right now, I think it would be challenging to take that approach in Canada, and also in the United States as well.
Yeah. No, that's a great point. So essentially, pragmatically, even if you like the idea of pool donors, you can't use them in Canada. So it leaves you the top three. There's nothing wrong with related or unrelated, but it's a lot more work, because you have to extensively screen them, and they may fail screening. Whereas with healthy volunteers, the anonymous donor approach, they usually stay with the program for a few years. Eventually everyone gets tired, but we're very grateful to our healthy donors because they keep providing samples, so we have that steady stream. The other thing to point out is, even if they screen appropriately, these days we bank the stool for 3 months before we use it. So we keep having the person donate, but we don't release the stool until 3 months' time. So when we recheck their HIV serology, it's still negative. Same for the hepatitis and everything else. And this also has other implications for the stool screening. So the bottom line is, this is an extensive process to try and keep what we're doing as safe as possible. And if you're doing it with a different donor each time, it's a real problem, just logistically. But the other issue is, if you're doing a different donor for each patient, you can't look at donor issues. So in the randomized trial we did with ulcerative colitis, we had two main donors, donor A and donor B. And what we found was that most of the successes were in donor B. So these sort of donor issues you cannot look at if you look at both stool, pooled stool, or just everyone having a different donor. You can then interrogate, and Mike Surratt and his team did this. I'd have to say that donor B does not look that different from donor F. We mainly used two, but we had to use a whole host of others when donor B stopped for a while. And I think the other emphasis is probably donor A is a little different. Now, donor works just fine for C. diff, but clearly none of the successes were with donor A for UC. So there probably are some donor issues, and you can only work that out if you use healthy volunteers and try to keep the same healthy volunteer for each patient. So the next issue is the preparation of the stool. Now, in terms of just preparing it as the patient brings it to patient, the donor brings it to you, they transport it on ice to the laboratory, hopefully a freshly given specimen, and that's essentially homogenized in a blender. Obviously, we don't use a blender, but a blender would do, actually, which is why the person can do this at home. And you blend it with saline and water, you filter it to remove particulates, and resuspend in saline or water. Now, your option, it will be common to more or less, that is the baseline for any FMT. as I say, it is simple. So this is why people are doing it at home without, of course, the screening steps. And that has its own issues. But you can either just give it there and then and have a big push to just time it so that when you get a donation, you give this to as many people taking part in the trial as possible. The next option is to freeze at -80. And then thaw, of course, at a time when you can give it to the patient. You can lyophilize, you can freeze dry. There is the issue of synthetic stool, but that isn't available yet. People are trying to make this in Canada and elsewhere, but we're far from understanding what is the therapeutic value of stool. It clearly has some in some diseases, but what is driving that, we do not know. So really it's between the top 3 that you're going to choose from. So Dina, any thoughts on what is the best approach?
Yeah, so in the beginning, when we first started our FMT program, we're using the fresh specimen, and it logistically is just a nightmare to arrange for the donor to come, process, give it to the patient. In the beginning, we have some donors who got nervous and they couldn't produce. So it's a real challenge. And so then there was a paper that came out showing that there is no difference in clinical efficacy, whether you use fresh or frozen specimens. And so we moved into the frozen model, and logistically it's just so much easier, and you can essentially treat patients on demand. So -80 is great because then it allows you to store your specimen for a year. Probably even longer. But obviously with -80, you need to have the appropriate infrastructure. You need to have the -80 freezers. And it's not readily available, especially in a more clinical setting. And so there's a recent publication. It's a very small case series where they were looking at -20 storage, and they're showing that clinically efficacy in terms of treating recurrent C. diff infection. There is no difference whether you're storing at -20 versus -80. But again, this is a very small study. So we had to take that into consideration. In terms of the lyophilized preparation, I think that hopefully is going to be the future, because storage-wise, it is way simpler. There is some small studies looking at comparing the clinical efficacy. Again, this is all in the context of treating recurrent C. diff infection, and it looks like when you lyophilize them and store them at 4 degrees, basically refrigerator temperature, the clinical efficacy is very similar when it's lyophilized versus the frozen versus the fresh. But again, it's in the context of recurrent C. diff infection. We don't know if that translates to other indications.
Yeah, so that's absolutely right. I completely agree. And I think you don't know, so this is very difficult to say for your study what you should do. What I would say is for UC, we thought fresh, it may not be the same as C. diff, so let's use fresh. That's got to be the best. But actually, towards the end, in order to accommodate the patients and get the trial done, we did move to -80 as well, and there didn't seem to be any difference. And indeed, for our follow-ups, some of those have received lyophilized preparations, and they seem to stay in remission with ulcerative colitis. So anecdotally, anyway, it just all seems to work. Lyophilize is the easiest. It's freeze-dried. It's much easier to handle. It's a much lower volume. There's less of a yuck factor involved. But to create it is a very smelly procedure. You need special equipment, of course, and you need a room that is heavily ventilated. But the advantage of lyophilization is as we scale things up, it does make it more user-friendly and easier to transport and better for the patient. So lyophilized probably is the future as long as it works in your disease. but you need equipment, only if this is something your institution is already doing. Otherwise, you're going to go with -80 probably.
Yeah, I agree.
Yeah. So the FMT recipient considerations, there's also the route of administration and bowel preparation. So you can give it via a retention enema, basically a 50 ml syringe, as in the right-hand picture here as you look at the screen. You just squirt it up there as a retention enema. You can use that same syringe attached to a channel and squirt it in through the colonoscope, going round the colon from cecum to rectum. You can give it via a nasogastric tube or an oral pill. We use 50, 60 mils, at least when we're giving it via an enema. I have to say, we're not sure how much volume to give. Do we need to give that much? Is it not enough? That's very difficult to say, although for C. diff, certainly 50 mils seems sufficient. So in terms of the route administration, Dina, any thoughts on best way to go?
Yeah, so again, this is a sort of a question that hasn't been fully addressed. If we just looking at from C. diff perspective, it seems like any of these routes of administration would work. And again, it just really depends on what's available at your institution. And from Health Canada perspective, what they're allowing us to treat as quote unquote standard care, not involved in the clinical trial, you don't have to do a clinical trial application. They are allowing us to administer a fecal slurry as standard care. So if you put that in context, then that does limit your options. You won't be able to do pills in that context. But if you're doing a clinical trial, then I think from convenience perspective and cost as well, that pills does make a lot of sense. It's the least invasive way. You can do this in an office setting. And from our experience, sort of surveying patients in treating recurrent C. diff infection, they seem to have a preference for oral pills. Just because it doesn't involve any sort of tube inserting into their body, so that is something to consider.
Yeah, so I think that's absolutely right. And actually, we are involved in a trial with Dina where her centre provides oral pills in Crohn's disease. Patients like it, although I have to say it's a lot of pills. And this is the other issue with lyophilized. Dina's centre gives fresh stool, as it were. If you can lyophilize it, it decreases the volume. So that's another advantage of lyophilization, is it allows easier pill creation. But clinically, and as at the moment, Health Canada doesn't demand that if you create the pills, you have this sort of pharmaceutical grade lab to do it in. You could basically do it with a fume hood. But that may change in the future. And certainly the easiest approach, if it is an issue, is either enema or via the colon. And my view is that it depends what you're doing it for. If it's just once, then colonoscopy is clearly the way to go if the site of the disease is the colon. Because the pill will deliver it to the colon, but it'll be mainly the right side. You would presumably get less sort of engraftment as you moved to the left colon. So for something like C. diff or UC, which can be a more left-sided than right-sided disease, if you have to give it many times, then probably the enema is the way to go. And that's what we do with ulcerative colitis, and it seems to work just fine, even those with pancolitis. So if you've got a colonic disease with particularly a left-sided colonic disease, when you have to give it many times, and enema is the way to go, and that's what most UC studies have done, at least, well, most of them, at least as on a continued basis. One only can be colonoscopy with C. diff, or can be enema, frankly, as well. When you've got a small bowel disease, it makes no sense to give it enema. So obviously the Crohn's trial, it has to be a pill when we're treating terminal ileal disease and right-sided colonic disease predominantly. If it's once, you could, I guess, use a nasogastric tube, although I would emphasize that that has been associated with high temperatures in some recipients. I think because you're giving fecal material to the duodenum or upper jejunum, where it's not used to seeing that sort of microbiome, and sometimes a person can have quite a bad reaction to that. We don't see that with the pills, certainly the pills from Edmonton, probably because they're designed to be released lower in the small bowel. But I emphasize this because if you're going to look at FMT to treat mental disease or to treat obesity, these are likely to be related to the microbiome in the small bowel, and pill has to be the way to go, in my view. You then think about bowel preparation, giving them PEG before you give them the FMT, giving them antibiotic therapy before the FMT, and for how long do you stop the antibiotics before giving the transplant. These are issues which are really not evaluated as yet. We just don't know if these have any value. But I would say that if you're going to do that and you're going to compare with placebo, you're either giving people placebo followed by a PEG enema followed by placebo, or you are going to give them antibiotics. Either way, you're either giving it for no good reason, which is unpleasant for patients, or you're not giving it at all, in which case, of course, they're not blinded. I think it's just best to keep it simple. So if you're doing it the first in for a particular disease, don't prepare the stool beforehand, just give it straight. It seems to work fine for C. diff, and it certainly works fine for ulcerative colitis. So no preparation at all, no laxatives before, no antibiotics before, just give them the stool. And then there's a choice of control therapy. Do you just not give them FMT? In the case of pills, do you give them an inert pill? In the case of enema or colonoscopy, do you give them water or saline for GI delivery, or autologous FMT? Any thoughts, Dina?
Yeah, so yeah, I agree that the choosing control is somewhat, it's an important issue. And when you look at the studies that has done the randomized, including the control arm, it's all over the place. I've seen it, there's no FMT, there's studies looking at autologous FMT. And when you're using autologous FMT, basically you take the patient's own stool, you process it in an aerobic environment, and so then it's no longer a control anymore, because you have in a way manipulated it, because during that processing, for sure, some of the microbes would for sure die off. And so in my mind, I just don't really see it as a real placebo, because you're also giving a treatment. It's an altered form of treatment. So in my mind, if you're doing, for example, if your design is using enema treatment, then I personally, I just feel that water makes a lot of sense. And you don't even have to color it. It's just water, as long as the patient is not seeing what you're administering, because when they have to go to the bathroom and they honestly cannot tell what you have given them. We have asked patients in our trial where we use water as our placebo, and we asked them if they could guess what they're getting, and they can't.
Yeah, so I would agree. We've had the same experience with ours. Giving them a retention enema of water has given the same results, because eventually you're putting water, fecally contaminated water, in anyway with a proper FMT, so it all comes out the same way. Although clearly, if you're giving a pill, the best way to go is with an inert pill as a placebo. The trouble with water is the person giving it for sure knows what they're giving. So the person giving it has to be separate from the person looking after the patient and also the person evaluating the patient for research. So logistically, that's one extra member of staff that you have to have if you're going to do it this way. With autologous FMT, in theory, you can have it all prepared in the lab and just delivered to you. And you can be looking after patients and still not know what fecal transplant is available. But it is a lot of work. And as Dina says, the problem is, in theory anyway, autologous FMT could actually be therapeutic. Although, so this is just thoughts on what we just said. And what I would say is that I thought we'd find evidence from C. diff, but it is no real sort of smoking gun as to what's going on here. So in this systematic review we did, if you look at those that use FMT versus vancomycin for antibiotic-resistant C. diff, so the people who failed an antibiotic, which could have been vancomycin at least once, this was the effect of FMT, pretty similar to autologous, which is the only trial that was autologous. So you can either say autologous seemed to not be as good as unrelated donors FMT, fecal transplant, or you could say it may have some effect because it worked just as well as vancomycin. Yeah, you could argue it either way, but the bottom line is, at least in theory, it's probably better to go with saline and water. And although you need an extra member of staff, in general, it's just easier. And then the question of how often, once per week, every day, and for how long, I don't think we just know that. It's just very difficult to work that out. Any thoughts, Dina?
Yeah, I agree. When we're treating any other indications except C. diff, where recurrent C. diff infection, it seems one treatment is enough. For all these other chronic conditions, I think it's not going to be one treatment alone. It's just like diabetes, high blood, hypertension. You need chronic therapy, and my view is that definitely you need to continue to do this, but how frequently do you need to do that is still unclear.
That's absolutely, completely agree. So unfortunately, this is what I said at the beginning, we can't give you a prescription for how to do this. What I will say is that transplant is a little bit of a misnomer. You're not transplanting anything. You are only transplanting a few organisms compared to the many that are there in the stool. So if you look at the change from baseline in patients with active UC in our trial over 6 weeks, in the placebo group, those that have got water, there's quite a lot of change. Don't forget, these are active UC patients with a lot of diarrhea. So yes, if you like, simplistically, there's 40% change from baseline on average. With those treated with a active fecal transplant, there was more change. It went to 50% from baseline. So there is a greater change from baseline. But a simplistic way of looking at this, and actually the proper engraftment studies will show something similar, is you are essentially engrafting about 10% of the organisms from the donor stool to the recipient. But most of the recipient organisms stayed just the same. Obviously, there's a shift, and you hope that shift is to the benefit of the patient, but this is not a wholesale removal of one set of organisms for another that the healthy donor has. It's just some of those organisms that they get. It does seem, by the way, that they're getting what we're giving the donors and not some other random change of microbiome, because they look more like the donor than they do to an unrelated donor. Or again, the main driver is whatever they were like before, they are like again. That is actually the main pattern in all of this. But to get to what Dina was saying, because you're not doing anything dramatic, unless the disease is very fragile, like C. diff, it's called difficile for a reason, it's difficult to grow, it's easy in some ways to displace. So one transplant is usually enough. But in other diseases where you don't know the organism and it may be a lot harder than C. diff, you probably want to keep giving it. And if you look at the experience of UC, most studies, positive studies anyway, have given it for 6 to 8 weeks. We gave it once a week, and that seemed to work just as well as the Australia study that gave it 5 times a week, which is just exhausting for everyone, by the way. So I would, for most of the studies, we go for once or maybe twice a week. We would not go any more frequent than that, and we go for at least 6 weeks. So these are the studies, remarkably similar. But as I say, the one study that was negative just gave 2 treatments and via a nasogastric tube. So that may be the reason why. Summary of that would be once a week, maybe 6 to 8 weeks, and just single is enough if you know you're dealing with a fragile pathogen. But again, just to emphasize, with the IBS studies, they've tended to just give it once a day for 3 days. There's one study that gave it for 12 days, but they only just gave it once or just for a couple of days. And the IBS studies have been all over the place and have generally been negative. And to me, you can predict that because they're just not giving it enough. You've got to keep giving it for a long period of time, not just for 3 days or once. I think the message is, if you're trying to make fecal transplant change disease, you need to commit to giving it for at least 6 to 8 weeks. And with that, we'll move on to regulatory considerations. Dina.
Well, thanks, Paul. And yeah, so I just have a few slides about in this regards. So both the FDA as well as Health Canada, they classify FMT as a drug. And a lot of experts in the field don't really agree with that position, because the definition of a drug is that you know exact, precise composition of that compound or the drug, and the composition is the same with each batch, and we know that is simply not true with FMT. But they right now they just don't know how else to regulate it. And so that's the way it is now. So it's being regulated as a drug. And initially, when FDA tried to regulate FMT, they basically said if anybody wants to do provide FMT either in a clinical setting or in research, you had to apply for IND, which is investigational new drug. And so this is again a very lengthy, lots of paperwork involved. And so there was a lot of there was outcry from the medical community, from patient groups as well, because this is going to severely restrict access to FMT, for sure. And so eventually they did a public consultation, and through the process they decided that they're going to settle on this enforcement discretion policy, basically meaning that if you are treating recurrent C. diff infection that's not responding to standard therapy, then they are not going to go after you. They won't prosecute you, but they do want you to have that very detailed discussion with your patients. You need to have this informed consent process. You need to really discuss with them in terms of the potential risks versus the benefits. So if you're providing FMT for C. diff infection in clinical care, then that's okay. You can do it without IND. For everything else, you need to apply for IND. Health Canada pretty much follows the footsteps of the FDA. And yeah, so again, if we are treating recurrent C. diff infection that's not responding to antibiotics, then we don't have to go through this clinical trial application process. But the minute that you're doing a clinical trial, even if it's for C. diff infection, you do have to do this clinical trial application. Next slide, please. So Health Canada, they did come up with a guidance document. And so this is, you can just Google it and you'll be able to find it. So it's gone through 3 revisions, with the last version updated about a year ago. It's not a very long document. And so if you're interested in this field, I would encourage you to take a look at this document, because it does have good information in terms of how they're regulating this in Canada. Next slide, please. And basically, the biggest concern is about safety, right? Because we do know that, generally speaking, from the C. diff literature, the short-term safety profile is excellent. But more recently, there has been a few case reports in terms of undesirable infections that are transmitted through fecal transplant. And so this was actually published in New England Journal of Medicine a few months ago, reporting transmission of ESBL E. coli in 2 immunocompromised patients. The indications, one was for hepatic encephalopathy, and the other one was in the context of bone marrow transplant. And one of the patients actually died as a result of this infection. And so the FDA and Health Canada, they came up with a big safety warning about that. And that's the context where they started to mandate that we had to screen for antibiotic-resistant organisms, because in this case, in the United States, that they traced back this infection to the donor, and they were not screening for antibiotic-resistant organisms in their donor program. And subsequently, there were 2 more cases where patients contracted enteropathogenic E. coli, and another one, she got toxin-producing E. coli. And these are products that were supplied by Open Biome, which, as you know, is a public stool bank in the United States. And so again, there was a big safety warning coming out in that regard. And so now, living in this COVID pandemic, there was another very recent safety warning from Health Canada, as well as from the FDA. Basically, they want all the FMT providers to be able to sort of demonstrate to them that you're screening for COVID to the best of your abilities, because there is, again, theoretical possibility that COVID can be transmitted by this oral fecal route, and that asymptomatic individuals can potentially be shedding the COVID virus. A bigger question is that we honestly don't know about long-term safety, because based on the C. diff literature, the longest follow-up is probably up to 5 years. That's the longest. And so we just don't have long-term safety data to inform us at this point. And that's why the AGA is partnered, they have partnered with a lot of the FMT providers. They're doing a registry trial at this moment. So hopefully, sometime down the road, we'll have some data in that regard. Next slide, please.
Just before you move on next slide, I would just interject that certainly Mike Surratt lab, where I work, they can detect, they have a stool test for COVID. And the plan is, when we get going again, is to bank the stool as I was describing before, but at that bank school, see if there's any COVID in it, and if there isn't, as well as having negative serology on the patient, we should be able to move forward with giving it as a transplant. But in theory, you don't want to give anyone COVID-19 through a fecal transplant. That would be a disaster. The other thing, just to warn you about Health Canada, the donor cannot be a healthcare worker because of the concern around antibiotic-resistant organisms.
Yes, that's correct. And because in the past, majority of our donors are actually healthcare workers, just because they understand the reason why we're doing this, and plus they're coming to work, and so it makes a lot of sense. But because of these reported transmission, Health Canada and FDA, they came out and they said you had to exclude healthcare workers. So if you're going to put in a clinical trial application with Health Canada, this is what it looks like. It's quite a bit of paperwork involved, and there are 2 modules. In the first module, there are these individual components. You have to fill in this application form. Basically, they're just boxes that you have to fill in. You have to tell them who you are, what institution you're working in, and then you have to tell them which centers you're in, and the qualified investigators. You also have to tell them about which is the REB that's going to be approving your study protocol. And then you will also include references to support your application. And you have to tell them a bit about your product. And so that's covered in this investigator's brochure. Basically, you have to tell them a bit about the physical, chemical, pharmaceutical properties of your drug, a little bit about the formulation. You have to tell them if there's any non-clinical studies performed, the effects in humans, and summary of the data that you may have, and guidance for investigators. And then you also have to submit this. Basically is the template. You basically just copy and paste your protocol into this form. It's called the Protocol Safety and Efficacy Assessment Template. And so basically you just have to copy and paste your protocol, fit them into the right boxes. Next slide, please. So then you would also include your actual study protocol. You include your informed consent form, and you'll get your ethics board to write a letter basically saying that they're going to approve your study protocol. You have to tell them who is on, which members are on your REB board. You also have to send them, if you have any prior FMT related applications, and if you have any ongoing trials. So that constitute module 1. In module 2, you have to tell them a little bit more in detail about your drug. And so there's, you should tell them a bit about the general information, your manufacturing process, characterization of your drug, description of the batches of the drug you have manufactured that you intend to use in your clinical trial, and if you have any stability testing results that would also be included in here. You should tell them about the composition of your drug, for example, how much stool you use and how much water or saline that you're using to do your manufacturing, for example. And so, yeah, so there are a lot of there's a lot of paperwork for sure. And what I would suggest that is that if you intend to put in an application, I would suggest that you consider setting up a conference call with Health Canada. And I have listed the email address here for you, because in my experience, I find them to be very helpful. And going through the FMT guidance document will give you some sense as to what they're looking for. And importantly, you do have to work with your institution because officially they are going to be the sponsor of your clinical trial. And once you submit your clinical trial application, most often they're going to have questions. And so they will send you information request. And so you should respond back to them. Most often they give you 48 hours as your turnaround time. You can perhaps request an extension, but probably no more than 2 to 3 days. If you need a lot of work in order to clear their question, my suggestion would be to withdraw your application and get your ducks in a row before you submit again. So quite often there's a little bit back and forth. That you submit your response to them, they have more questions, and then you send it back. So that can go around 2, 3, 4 times, and eventually they will stop bothering you. And then there is a 30 days of default. Essentially, they have to issue a no objection letter to you if they have no more questions and if they're happy with your responses. So once you get your NOL, it's a big step. Congratulations. Quite often, they also have conditions attached to their no objection letter. For example, the most recent application that I submitted, they wanted me to submit a log of all our lot numbers every 6 months that we use to treat our patients. And I also want to remind you that if you have any SAEs during your clinical trial, not only do you need to report to your REB, but you also have to notify Health Canada at the same time. And then once you finish your study, you close out your study, make sure you also notify them so that in the future, if there is any more safety warnings, they don't come to you and want you to respond to them in terms of how you're going to address those safety concerns. So that's all I have.
Thanks very much, Dina. So I think hopefully we've shown you need to choose your donors carefully if you want to do a fecal transplant trial. We would generally recommend a small number of healthy volunteers, not one. You've got to have more than that in case that healthy volunteer gets ill, but just a small number. Pill for small bowel diseases, enema colonoscopy for large bowel diseases. Most trials will need once a week for at least 6 weeks, but of course that isn't written in stone and you can vary it. What I would say is that this is a very promising area, and in the immortal words of Tyrion Lannister, the future is shit. I would like to thank a number of people from my centre, and Dina probably has an equal number in hers that have been involved in this, particularly Melanie Wolf and Gail Capelli running the ulcerative colitis trials, Christine Lee, who have been an infectious diseases consultant, been very involved in those, Michael Sret, the microbiologist, and his postdocs listed there. With that, I would like to thank our funding partners listed here, and we're ready to take any questions.
Great, thank you, Paul. I just want to remind people again to use the chat box at the bottom to enter your questions. We do have some to get us going, and we don't have a lot of time left, just about 5 minutes or so. So I'll field the ones we do have. And the first question, I think I'll ask you, Paul. Are the healthy volunteers, are they instructed to take any special diet, such as a high fiber diet or no meat or anything along those lines?
No, in the future we may be able to understand what is good or bad in the diet that we eat, but we simply don't know that yet. And it's exhausting enough being a volunteer. We don't demand that they take a special diet. We don't assess their diet in any truly formal way to exclude people, for example, who just eat McDonald's burgers all day or whatever. But the reason we don't is, for all we know, is that might be perfectly fine. So as long as the key thing is they're healthy, what diet and they're not obese. What diet they take, apart from that, we don't legislate. Dina, do you have anything to add to that?
Yeah, I agree because donors are so hard to come by. But when we are recruiting our donors, part of our process, we do try to get a sense of what their diet is like. And we are just very fortunate that just by chance, the donors that we have recruited, they're just very conscientious, they're very altruistic, and they're very health conscious. And so most of our donors, they do eat a very healthy diet with lots of fibers. So I think we just, we lucked out.
So this next question, I think I'll pass on to you, Dina. It does involve donors, but how are you adhering to the guidelines by Health Canada such that the donors need to be known to either the physician or patient?
Yeah, so so all the donors, I have recruited them personally, and so I know them, and so that is sort of one of the criteria with Health Canada, is that the donor should be known to either the practitioner or the patient, and so asking the patient to recruit a donor these days may not be all that easy. And as Paul had discussed earlier, that sort of having a patient-directed donor, it logistically is just very challenging and very costly for the healthcare system as well. And so Health Canada, in their guidance documents, they do have a list of things that you should consider screening for, and that list is quite extensive. It's a page long, and they even talk about things like Creutzfeldt-Jakob disease. And I think for most centers, we're not screening for that. So I think there is a little bit of judgment call as well. And I think as long as you are, you choose your donors carefully, you sort of get to know them a bit, know their lifestyle. Because no test is perfect, and plus you're screening them sort of every 2 months, for example, during the quarantine period, things can still happen, right? And so there is no perfect solution unless you're testing for every single batch every time when they make a donation. You just simply cannot rule out these things. But we do the best to the best of our abilities.
So another question here, do you anticipate stool banks, either provincial or institutional, being started? And if so, how would they be regulated?
Yeah, so that's a very challenging question. Ideally, it makes a lot of sense if you have a provincial stool bank. Right now in Alberta, there are basically 2 centers. So one in Calgary, one in Edmonton. The biggest challenge really is funding. How do we secure funding for that? And within Alberta, we have had a lot of discussions with Alberta Health Services, and I think at the moment they just don't really feel that it is going to be cost. They won't be able to recover the cost for that initial investment, because then you're talking about eventually you want a GMP type of facility if you're going to go that route. And so I think a provincial stool bank may not be cost effective. And so I think if we want to make it cost effective, it probably has to go to a national level. But again, who is going to fund that kind of a program? That's in my experience, I find that that's the biggest challenge. And then even if you can get funding together, yes, as you alluded to, how are we going to regulate? Who is going to regulate that stool bank? Right. And I think there is some parallel with the blood bank. I think perhaps we can look at the blood bank and the tissue bank as a model.
Thanks, Dina. So I think we'll just have time for one last question here. Is there any work being done on fully understanding what elements of the microbiome are most responsible for the positive results we're seeing in studies? And if so, could this microbiome be replicated in either an oral or a rectal probiotic without all the risks of the remainder of the fecal transplant?
Well, I'll answer this one. There's certainly a holy grail to all of this, but as yet we don't have any clues as to what organisms may be driving this. When I say that rather negatively, if you look at the graphs I showed, it was deliberately quite generic, because whilst we found organisms that might be harmful or effective given in the donor or recipient, none of them stood up to rigorous statistical analysis with multiple testing. And indeed, the Melbourne group, who also had a positive result, they did show some microbiome signals, but I'd have to say we can't replicate that. So this is the problem. Trials, by their very nature, are going to be relatively small in this area. and you'll never have enough information to do multiple testing. So I think just doing randomized trials will not get us this answer. We need other epidemiological studies, such as we're doing in Imagine, and we'll probably need to triangulate microbiome information from all sorts of sources till we get to that state. But the hope is very much that one day we will, and that we won't have to give fecal transplants at all. For a given disease, we give a certain number of curated organisms. But I just don't think we're there yet. Although certainly the industry is trying, and who knows, maybe successful.
Thank you. So before we wrap up, I just first of all want to thank our presenters, Dr. Paul Moayyedi and Dr. Dina Kao, for leading this webinar. I will let you know we are planning on keeping an archived version of this webinar on our website, so you can share it with, review it and share it with your colleagues. We will be sending out an evaluation form, which you'll get by an email link in the next little while. And so we encourage you to please fill out that evaluation form. It'll help us shape these webinars. We do plan on having these monthly on different topics. So encourage you again to share with your colleagues this opportunity to learn about what Imagine is doing and some of the very topical issues in the brain gut area of research. So thank you to everybody for participating, and a special thanks to our speakers.
Thank you.
Thank you.
Bye, everyone.
Goodbye, everyone. Thanks very much.
Thank you.